Good morning, and thank you for joining us for the first webinar in our Physician Leadership for Clinical Integration webinar series. The topic of today's presentation is Physician Alignment Strategy, Foundation for Clinical Integration. My name is Vicki Radcliffe, and I will be your moderator today. Before we get started with our presentation, I'd like to review just a few basic reminders and instructions for our audience. First, if you are having any issues getting online into this presentation, please go ahead and call the Integrated Healthcare Strategies front desk, and they may be able to help you. That number is 612-339-0919. Also, please be aware that all participant lines will be muted for the entire presentation in order to reduce noise and distractions heard on the line. Midway through our presentation, and again at the end, we will allow some time for questions and answers. If you have a question you would like addressed, you may type it in and we will read it off for you and then answer it. To do so, click on the Q&A button you see at the top of your menu bar. A dialog box will open. You can type in your question, submit it, and again, we'll do the best we can to make sure that it gets answered. Our presenter today is Jim Rice. He is an Executive Vice President with the Executive Compensation and Governance Practice here at Integrated Healthcare Strategies. Now I'll pass off to Dr. Rice and let him get us started. Jim?
Thank you, Vicki. Hello, everyone. We're delighted you're investing some additional time with us to launch this three-part webinar series. About 3 years ago, many hospital and health systems became more formal in their attempt to map a roadmap, if you will, in their journey for clinical integration and accountable care. And now, of course, with the new regs out for the accountable care organizations, we're starting to see what the federal government is defining to be some of those key elements of that journey for clinical integration. One of the things that's become clear, I believe, for everyone that's on this webinar and certainly in our working relationships with hospitals and health systems is the central role that physician leadership and physician alignment must play. We've identified 3 imperatives for this journey. You'll see on slide 3, the first imperative is to be more intentional about your physician alignment strategy. And then secondarily, and related to that, is to invest more intentionally and more formally in the development of physician leaders, both informal and formal. We will be addressing that in a separate webinar on May 11th, looking at some of the competencies and learning methods that are working well across the nation for physician leadership academies. The third imperative is to look at governing the array of physician-hospital arrangements. There are informal and formal co-ventures, councils to have joint planning, and a wide variety of other areas that sometimes create confusion if you don't have a roadmap to weave your way through the governance and strategic decision-making processes important for that physician enterprise to work well. So on May 25th, we're going to focus some attention on some of the structures and strategies that seem to be working well across the country to oversee and govern the physician enterprise. But today we're going to look at where it all needs to begin, which is physician alignment and moving from concept and philosophy to structured opportunities for clarity and focus. You'll see on slide 4, we've organized this webinar into 3 blocks. We're going to remind all of us so that we're grounded on the rationale for a solid alignment strategy. We're going to give a discussion about some samples and key elements of a physician alignment strategy. And then we'll be spending some time on how organizations are finding it efficient and effective to move through a process to build the strategy and then use it as a means of making sure that the organization broadly walks the talk of alignment. As we look at the very first of our 3 components, why have an alignment strategy, we hope it's self-evident, but sometimes it is useful to remind your various planning participants and partners and collaborators to be explicit about the need for this. And so after this short webinar, you'll be able to use these slides for your own benefit for orientation and education of your various partners. One useful insight is shared with us for this purpose by Chris Van Gorder, President and CEO of Scripps Health in San Diego. He says that, understandably, we need to partner and work more closely together if we're going to balance the needs of great care, lower costs, and economic viability and vitality of all parties to the process of developing and executing a physician alignment strategy. On slide 7, you'll see 12 common challenges and dilemmas that many of us are wrestling with. I won't take your time by reading through all 12 of them, but you can use this as a checklist. Some organizations have found it helpful to put this into a small web survey and ask your various physician and management and board leaders to indicate on a degree of a scale of 1 to 5 which of these are most important drivers for your situation and your need for, or to build the case for, a little bit more formal, a little more structured approach to physician-hospital alignment. And one of the things that you'll see on items 8 and 9, item 8 says, a lack of options for private practice physicians that aren't interested in employment. We'll be talking about this in a few moments in this webinar. The alignment strategy is essential, whether you have 100% of your physicians employed or only 15 or 20%. The concept of understanding where you're going and the central role that physicians have to play in that is critical. Item 9 is also called to your attention by acknowledging, although the medical staff is still largely viewed across the nation as an anachronism, it's something we are wrestling with for accreditation. It does serve a very essential and important purpose as it relates to medical staff credentials, privileging, quality of care, and the like. But also, it's increasingly difficult to get full engagement of the best and brightest physicians sometimes. And so you'll be hearing later in this webinar that physician alignment must involve several subcomponents, one of which is a reconsideration of how best to redesign the medical staff as we move through our joint planning activities for alignment. There are certainly fiscal pressures on both the physicians and hospitals as we are being driven to work more closely together and to align our economic interests. The American Hospital Association has found that 74% of recent hospital CEOs in a survey are being approached by physicians seeking a wide variety of employment and aligned contract arrangements. These are among several factors that you'll see on 9 that are driving us to be more formal, more structured, more effective in not just the design of a physician alignment strategy, but the kinds of building blocks of action necessary to breathe life into that strategy. We have changes underway in payment, the venues in which care is being provided, the reliance on records for better informed clinical decision-making and electronic medical records, treatment that is moving from all size fits or one size fits all to much more personalized. And many of us believe that the digital age will allow customized and personalized not just medical records, but treatment and diagnostic protocols. All of these require physician engagement, understanding, enthusiasm, and alignment. There's another fundamental shift going on in our industry as shown on slide 10, and this is the migration over the last several years from the 15-minute encounter that you see on the top line of 3 green boxes to the current stage where we're trying to better manage 15-day episodes of care and getting coordination from the many clinicians involved in that care delivery activity. And we are anticipating the move to, as we fully appreciate the presence of chronic disease, that men and women over the age of 60 and 70 that have chronic disease are looking for long-term relationships with their healthcare system and with their medical care providers and coordinators. You'll see that over this several-year shift, not only from 15 minutes to 15 days to 15 years, but the shift to care is moving from largely inpatient to more outpatient. And as we see in the orange boxes on the bottom of this slide, we see some of the behaviors and strategic initiatives in our healthcare organizations from the 80s through 2005, looking at diversifying to protect assets, scrambling for new revenues. And while those certainly exist today, we are moving into an era now where these silos of care aren't serving us well. The decision makers are facing uncertainty, tension, pressures, and anxieties, and these get in the way of developing a physician alignment strategy, but they also build the case for the need of a new, fresh, efficient, and effective way to make joint decision making work well in a physician alignment strategy. Moving into the future, by the summer of the year 2020, we believe a premium is going to be placed on those organizations that can deliver a culture that is patient-centered, performance-driven, and values-based. That all will require new and more positive and more productive working relationships with our physicians, and supporting and undergirding all of this, of course, is the need for physician alignment. On slide 11, you'll see why that it's so difficult in most of the hospitals and health systems around the nation to achieve alignment. This is a real org chart of physician leadership of a hospital that has some teaching programs. Clearly you can't read it, but the intent is to see the amazing array and complexity and the fragmentation of our physician leaders. In each of these boxes is a physician leader. When we were asked to come in and do an alignment audit for this hospital organization, they weren't aware of how many physician leaders they had. They weren't aware of how many dollars were moving to these physician leaders. 33% of the physician leadership positions did not have job descriptions. There was not an existing philosophy statement of why alignment was important and what it should look like. And on the far right side, they had 56 compensated medical directors, none of which had any formal performance management tools or philosophies being embraced to execute on the potential promise of a physician alignment strategy, even if it had existed. The last couple of slides that we will look at to reinforce the need for this physician alignment strategy, and again, we emphasize we hope you'll use these slides for your own internal workshops. On slide 12, we see the bottom of this slide indicates the alignment vehicles that you can consider, and many of you have been putting in place these precise structures for alignment strategies over the last 2 to 3 years. Co-management is one, new governance models, completely new integrated delivery systems, and these enable and support the change that is underway with payment. Pay for performance is, of course, on all of our plates. This new regulations that have just come out last Thursday on accountable care organizations speak volumes about value-based purchasing, bundling payments, even new approaches to partial capitation and global payments, all of which requires us to build new partnerships with our physicians. We all have to be at the table defining the care maps that are going to guide care and how we are going to work together to get savings, and then, of course, how we will arm wrestle together to make sure those shared savings are passed back to all of the parties to the journey for clinical integration. Health leaders recently organized a roundtable that looked at some of the lessons learned from Sanford Health, Gunderson Lutheran in Wisconsin, FSM Healthcare, and Virginia Mason. You'll see on this slide that as they are definitely walking the talk, they have come up with not only philosophies and strategies for alignment, but they are actually building initiatives to breathe life into those, which we'll talk about in a moment. Some of the elements and conclusions on the left side of this screen suggest some of the elements you'll want to take into consideration as you build your physician alignment strategy. A common language that both employed and related or affiliated but independent physicians can use as you look at the future. How you can collaborate on a shared culture even when you're not employed by the health system. How you articulate together clear goals and strategies. How you will define and invest in physician leadership, information, sharing risk. All of these are essential. So let's look at some samples of what a physician alignment strategy needs to have in it and why it is so important to be explicit and formal about it, not informal. As I've mentioned before, as we start to look at some sample strategies, it's essential that you realize that employment is not the only answer. We must, in fact, have even greater reliance on a formal physician alignment statement of strategy and philosophy if we have a large amount of our inpatient and outpatient revenue activities dependent on independent physicians. And so we see on slide 16, there are many ways to look at this close working relationship between hospitals and physicians. The key is to always have it driven by patient-centered goals. There are some resources that you can pull off of the internet. I've suggested that for your consideration on slide 17. When you look at some of the work that the Mayo Clinic has done, arguably one of the oldest and most successful integrated care models, which has been developing and experimenting and refining for several decades what they mean by physician alignment. They've published some documents on their website that look at encouraging the embrace of 4 cornerstones: creating value, coordinating care, providing health insurance for all, and how they are looking at reforming the payment system. They would not be able to be so bold or effective unless they had good physician alignment, and they have found ways to move beyond strategy into action. And so as we look at slide 18, part of the debate that you will be having, if you haven't already in your organizations, is when we're on this journey for clinical integration and we're looking for alignment, who's going to align with whom and how will that happen? Some are looking at this as a hospital-centric process. Yes, they're willing to put the patient in the middle of this, but they want the hospital to be embracing and controlling the physicians, whether employed or independent. We're finding over the last 4 or 5 years in working with hospitals and health systems around the country, the ones that are able to establish success faster and are identifying sustainable change in their journey to integration are walking the talk with physician alignment that has the physicians embracing, whether employed or independent, much more prominent roles in the joint clinical and administrative and financial and care decision-making. And so we see a migration from the hospital being the center to physicians being not just the center, but enveloping all of what we do, of course, with the key message that the patient must, at the end of the day, be the center of all this. On slide 19, then, we look at some illustrations, some language that we would encourage you to think about. If you have not developed a statement of physician alignment that is received at least as much thought and rigor as you have invested into fine-tuning your mission and your vision and your values, we think you're missing an opportunity for success. We would encourage you to think of the kinds of words that you see on slide 19 to look at building that philosophy and that strategy. Build the patient at the center of all that you do. You look at what it takes for explicit partnerships where there is trust and respect among those parties to the journey for clinical integration. You start having conversations about what would it mean for us to truly be good stewards of the assets entrusted to us. And most of the people we see participating in this webinar are tax-exempt hospitals and hospital systems. We're going to increasingly be held to a higher standard of what we mean by being good stewards, and that requires new, energized partnerships and alignment with physicians. We also have to be servant leaders, and we have to look at how we are designing, developing, and deploying scarce resources through absolutely more serious and more structured joint decision-making on how we do strategic planning, budgeting, capital allocation. Physicians have to be at the table in each of those decision-making processes if we're ever going to hope to enhance the cost-effective, as you'll see in the middle of this slide, the three dimensions focused on health: protecting health, promoting health, and the restoration of optimal health. These types of words will not mean anything unless you debate every word that you put on the paper and have small focus group discussions with your physician colleagues to build a sense of ownership of what those words mean and how you're going to walk the talk to get them implemented, how you're going to be ready for shared risks and rewards and to really marry your reputations as suggested on the bottom of slide 19. So you'll be able to come up with your own words that make sense for your unique situation and your setting. I'm going to give you a chance to see if you've got some questions or comments on what we've said thus far. All we've done in the webinar so far is to encourage you to, with your partners, especially your physicians and board members, be explicit about the need for the case for physician alignment. Most of you, I hope, have been there for the last couple of years. We want you to be more intentional, more structured, and more formal. And so as we start to look at some metrics for alignment, we've identified 12 for you in the next couple of slides, but I want to pause briefly and see if you have any questions either on the case for alignment or on the need for an explicit formal statement. The rest of the webinar will go through and give you some examples of measures of alignment as well as some process ideas on how to build that strategy and the action plan to implement it. But first, any questions or comments at this juncture?
Okay, sounds good, Jim. Let me just jump in here real quick and remind our audience how they can ask a question if they'd like to do so during our break here. Just go up to the Q&A button on the top menu bar. A dialog box will open. Just type in your question, click submit, and we'll get it on our end, be able to read it off and answer it for you. So take a few minutes now. Thank you.
We'll pause for a moment, see if you have any questions or concerns or comments.
While we're waiting, I'll just go ahead and remind our audience that you will be receiving, as a participant of this webinar, a PDF copy of the slides here that were presented to you following your webinar. So you can look for that in your inbox.
I don't see any questions yet. Just pause for one more moment, and then we're going to start moving through metrics of alignment that are useful to have stapled literally to your statement of philosophy, because the alignment philosophy and strategy doesn't mean anything unless you've had formal, critical, crucial conversations about how you're measuring that. So let's take a look at a few that we've found important. On slide 20, you'll see 7 identified. There are a few more on the next slide. The first is that the physician in the hospital must have a shared and common vision and the plan of action of how to breathe life into that. And it can't be developed by the hospital managers and board and given to the physicians and ask them what they think about it. As most of the folks I see, I know as few people on the webinar list, you're sophisticated enough to know that they have to participate if you want them to own it. The second metric, and you can convert any of these into, again, a simple web survey or a chance to have structured interviews and conversations about the degree to which these exist. You ask your partners what are the factors that are likely to get in the way of you achieving these metrics of alignment, and what do they believe are 2 or 3 actions you could take to remove, reduce, and work around those obstacles to these metrics. And the other side of the coin, of course, is what would your physician partners and collaborators identify as one or two actions that we could all take together to make sure these metrics are more likely to be occurring. The third one is that you actively engage in leadership roles in co-managing and co-decision-making on planning, capital allocation, budgeting, service line development, outpatient outreach, what you're doing to earn referrals. Every key dimension of clinical service delivery and clinical integration requires not only physician involvement, but increasingly many of you, I notice on the folks with this webinar registration, are using the clinical partnership model where there's a physician leader and an administrative support partner for most of your clinical departments, service lines, and service initiatives. The fourth one is to look at actively getting physicians participating in the efficiency side, not just the clinical quality and safety. Metric 5 is the degree to which physicians are actively engaged with you to find new physician partners to take on financial risk. The sixth is to look at embracing compensation. Our firm for 20 years has been involved in looking at how compensation for executives and now increasingly over the last 5 years for physicians and physician leaders, what are the economic incentives to align your activities? Although there is a great deal of scrutiny by Medicare and by IRS to make sure those incentive compensation arrangements are legal and practical, you also have to make sure they are effective. And linking new forms of talent management and performance management are important elements that must be hardwired into those compensation discussions and to the compensation formula. The seventh is that you, of course, embrace quality. That's usually where a lot of the alignment starts, but it now must move beyond that into the efficiency and to the finance arenas. Referrals are important for many of you. The physician partnership and alignment is critical to have that referral relationship work smoothly. I won't go through the rest of these. You can see them on slide 21. The important message we want you to take away is find your own top 10 metrics that alignment is working well for you. Use those metrics not only in your planning process, but you should be doing quarterly reviews on the degree to which those alignment building blocks are present and working well for you. Most of you have mixed model medical staffs. On slide 22, we're sharing with you on the left you have less integrated medical staffs, and on the right, fully integrated. Most hospitals over the foreseeable future from now through the summer of the year 2020 will not be anywhere close to the right side of this chart. And so the challenge is how will you develop and have successful a physician alignment strategy when only a portion of your medical staff are employed. And so what we'll want to make sure is we examine actions that you can take to move along wherever you're comfortable on this alignment continuum. A way to do that best, we're finding, is to take 5 elements into consideration as you're developing your physician alignment statement of philosophy and your alignment strategy. It must, of course, be built on the bedrock of a shared and well-owned and even enthusiastic embrace of a vision statement. How will you work together, and how can you articulate the headlines of the newspaper article? Or how would you be able to define that a patient-centered care experience for all patients, whether the young married couple that's having their first birth experience, the 85-year-old woman that's got chronic disease with comorbidities, how would they articulate a superior clinical and patient care experience? How would you distill that into a vision statement that is both developed and owned by you and your physician colleagues? The rationale must be explicit. That's why we spent as much time as we did giving you some ideas about the case for alignment. You can't allow or assume that will be informal. It must be formal. The third element on slide 24 that we'd like you to keep in mind is it must all be hardwired and tied to measurable goals. We've tried to give you suggestions on some generic imperatives or metrics for alignment. You need to have conversations where you spell out a minimum acceptable level of, or a proxy indicator of those metrics for alignment, a maximum probable, and a more likely, and you'll budget on the more likely metrics of those strategic goals. Engage your physician partners and colleagues in explicit, structured processes to answer the questions about measurement. And then you also need to be able to envision different methods of alignment to execute and implement on the promise of the strategy. For example, there's a number of factors that we would encourage you to keep in mind as you start rolling out initiatives to accomplish your efficient physician alignment strategy. On slide 12, there's a number of elements that we would encourage you to keep in mind, not only the owned groups in one single practice. That's a structural way to get at some of the alignment that you will want. Some of it may be around a more disciplined and more effective and more structured recruitment strategy that is guided by a formal medical staff development plan. In the mid-'80s, many hospitals developed a medical staff development plan focused principally on recruitment ideas, forecasting when the physicians would be likely to retire by physician, by specialty, when they would start to slow down their practice, how would you get physician partners to help you define and build that development plan. But it's important now to go beyond that medical staff development plan. More than a recruitment plan, it must hardwire into your quality, your safety, what you're going to do with your hospitalist programs, how you are approaching intensivist support in your critical care units. And increasingly now, we're starting to see organizations innovate on substantial benefits for aligning with you. We've taken to call this a clinical associates program on the bottom of slide 25. We also somewhat tried in a humorous way to look at this as a MSO on steroids. It involves a new approach to CMEs, physicians in private practice, to have an incentive to align themselves and their practices, their professional and their personal wherewithal with you for the long haul. They are literally card-carrying members of a clinical associates program. They have social and legal compacts and agreements that they sign where they use the best faith effort to interact with your various education programs, management support, group purchasing, and any number of different activities. We have received some requests to put a webinar together just on the clinical associates program. We're likely to try and do that later in the summer. So how do we go about building this physician alignment strategy? It's essential to move from just philosophy through strategy to the substantial investments and initiatives that you're going to have to do. We would encourage you to make those initiatives and those investments organized into 5 interrelated sub-processes and tangible documents and results that guide your investments. These are illustrated on slide 28. The thing that is common to all of these is, as suggested on the bottom of the slide, is physician engagement. We have found repeatedly over the last 36 months, as we have been working with organizations to develop physician alignment strategies, to develop the roadmap for their clinical integration journey, as we help them develop investments into co-ventures and co-management activities with their physicians, as we help them look at new forms of incentive compensation and pay-for-performance arrangements, all of those are going to be shallow in their success and in their viability and their sustainability unless you build in very explicit and formal physician engagement mechanisms and strategies. So when you harness their time and talent and energies through these engagement activities, you'll need to capture conclusions that you all own with some enthusiasm into these 5 books we've illustrated. One is the Medical Staff Redesign Plan. An important way to walk the talk of a physician alignment strategy is to get a group of 9 to 11 physicians that represent your key medical staff sections, and even if you 3 or 4 years ago went through the painful process of redesigning your medical staff, streamlining your committee structures, you need to do that again. And this medical staff redesign needs to breathe as much modern thinking and as much energy and life into the sections, the structures, the committees, the meetings, the minutes that you have for your medical staff as you can possibly do it. The second of 5 key building blocks for this physician alignment philosophy and culture and strategy is the Medical Staff Development Plan I referred to earlier. It must be built on a clear forecast. You must do computer modeling on the number of physicians, the number of admissions, the number of outpatient visits, the amount of dollars that are associated with each of your physicians, and on a 5-step process over the next 15 years. Who will be retiring? Who will be slowing down? What are you going to need to do to recruit those? And as you recruit new physicians into the medical staff or into your employment arrangements, they are going to have to understand what you mean by physician alignment, what the philosophy is, how you walk that talk, how you recognize and reward physicians in that. So the Medical Staff Development Plan also needs to be brought current and made more formal, more modern, more aggressive, and bolder as a component of your physician alignment strategy. The third element is something called a clinical governance plan. For those of you that are very comfortable with doing Google search to enrich your strategy development, I would encourage you to go through Google to the Department of Health and the website for the National Health Service in England. They have pioneered 10 years ago the concept of clinical governance. It's more than shared governance, which tends to be focused in on nurse engagement in the governance in clinical care process design activities. This is an umbrella concept that we think needs to be in the center of your physician alignment arrangements. It embraces everything from quality and safety, but it gives a more intentional leadership position and a visible role for physicians to be involved in governing the clinical affairs. Sometimes these are rolled out through a clinical council. I'm aware of a clinical council at Abbott Northwestern Hospital here in Minneapolis that meets every Thursday with physicians and nurses and managers sitting around the table looking at actual cases and processes. How can we make the care delivery mechanisms as high quality, as safe, as efficient as possible? That's going to be fundamental to achieve cost savings if you hope to try and share those. So clinical governance is a very important concept. There are manuals you can download free from the National Health Service. Don't tell your physicians that they come from England. Adapt them for our words, our spelling, our realities. But that disciplined approach you'll find beneficial. The fourth component that we believe also is absolutely essential to your success with physician alignment is to have scores of additional physicians that are ready, willing, and able to assume both formal and informal physician leadership roles. Most of you in an average-sized hospital will have anywhere from 10 to 50 part-time or full-time physician leadership. Unfortunately, many of you are like I was in the mid-'80s when I was involved with building the Allina organization and looking at physician alignment in those bygone eras, we would use medical directorships almost as a bribe, as an excuse to get their attention focused in on some of our activities. That won't work anymore. It must be more intentional. You must have formal job descriptions. You must develop mentoring programs. You must have different ways to share knowledge so that physicians are not only given a title and a position, but they're given a fair chance to succeed in those positions because they have the knowledge, the skills, and the attitudes necessary to be successful. You need to have debates with your physicians about something called the Physician Leadership Competency Model. If any of you on this webinar are interested in that, we can share samples of those physician leadership competency models with you for your benefits. The key thing that we find is not just classroom learning. Physicians, over the last 15 years, when we started a program at the University of Cambridge in England, the business school there, physician leaders said they wanted to learn leadership like they did medicine, not sitting but standing, short meetings, case or patient-focused or case-focused learning opportunities. And very importantly, they wanted the equivalent of that hard-charging, sometimes assertive and pushy chief resident. And so mentoring for physician leaders is absolutely essential. The last component, and we're near the end of our webinar, is the physician recognition and reward. You must continuously refresh your sense and your invitation and your effectiveness for physician participation and ownership and full collaboration in your alignment strategy building and, very importantly, in the implementation of your physician alignment strategy. Physicians are motivated like money, like all of us, but I would encourage you to not, please do not just think it is new forms of incentive pay. Physicians are motivated at the end of the day what is best for their patients. If you keep the patient in the center of all of these activities and you align around how the care experience can be better for them, if you align around the patient and you remove all of what the physicians often call bureaucratic and administrative BS that gets in the way of driving toward patient-centered care experiences, they will love it. And if you start to identify the physicians that are going above and beyond, that they get it, that they're walking the talk, you need to recognize them with pats on the back, with thank yous in the hallway, with recognition that involves ads in your website, ads on billboards, incentives. All of this needs to be documented. It all needs to be within IRS standards, but it is very important to make sure that it happens. The other thing that is essential is that you invest as much on talent management and performance management for your physician alignment initiatives and your physician leader partners as you do for your middle managers. They need job descriptions. They need annual performance plans that are linked to measurable metrics. They need support. They need quarterly reviews. They need an annual 360 performance review. Modern performance management must be an element of your physician alignment activities as well. In the last few minutes that we have, we want to acknowledge that the alignment can take many forms, as you see on slide 29. It moves from the traditional medical staff on the left all the way to full employment. Some of the structured elements of your strategy rollout will be on the larger boxes underneath, moving from the left. Your physician alignment must deal with staff privileges, awards that relate to their participation in the medical staff. It moves through IT quality initiatives, then service line collaboration, professional service agreements, MSO agreements that allow you to support their practices and their employees in those practices. This is where the Clinical Associates Program, practice management support, training for office staff are important inducements for the alignment to take hold and to be vital over the long term. Joint ventures, of course, are a part of it. Most of the argument will be about how you define downstream revenues that come from referrals, the ancillaries, the post-acute inpatient management and post-acute management, ambulatory surgery, full service contracting, which you will be going into with the era of accountable care organizations, and of course, a new approach, completely reinventing how you define performance bonuses. They have to do more than fog a mirror to get the performance bonuses in the future from your physicians and your physician leaders. We're going to have to hold them to important and high standards, but when they perform, they have to get the recognition and reward they deserve for that. That will reinforce your ability to keep them with you on continuously refining your alignment strategies as well. On slide 30, you'll see that the process must build up from the market. The needs of people and patients in your area will drive not only the kinds of physicians that you want, the kinds of physicians you will need, the kinds of service line managers that you'll want, the patterns of quality and performance that are going to pressurize your organizational vision and goals. In the middle, you'll see that conducting SWOT analyses of the opportunities for alignment, strengths, weaknesses, opportunities, and threats. Make sure physicians participate with you in that evaluation of your existing alignment and how to make those alignment strategies better. Do financial modeling of the implications financially of different alignment mechanisms, and build in a blueprint to do this in an intentional and structured way going forward. We've covered a lot of ground for you. The main thing we wanted to accomplish in this webinar is for you to do three things: to build a case for alignment that is a little more formal, a little more structured than you've had it in the past. Second, to make that alignment strategy more than just a general philosophy statement, although it must begin with a philosophy statement. Build in metrics of performance, build around those metrics of performance substantial recognition and reward, and we think you'll find it much easier to sustain physician engagement that you will need to have success on your journey toward clinical integration. We'd like to go to a short time for questions, and thank you very much for all that you're doing in your local markets to strengthen healthcare and to enhance physician alignment.
Great, and thank you, Jim, for all that great information. As Jim noted, we'll go ahead and open up our time for questions now. I'll go ahead and start with the first few that have come in, but you can still get your questions in line. I'll remind you one final time that you can do so by just clicking that Q&A button at the top of your menu bar. Quickly, I want to divert your attention to the slide currently on your screen. Here we have Dr. Rice's contact info if you would like to have a discussion with him following the webinar. That said, I'll get started with our first question here. Jim, this participant asks, how do you see the difference between a medical staff plan and a physician alignment strategy?
Thank you. It's a good question, and many times over the last 5 years, hospital leadership thought that all they needed was a medical staff development plan, that would be the vehicle for their alignment. The medical staff development plan, however, is principally focused on physician recruitment. Where are those needs out in the future for primary care and specialists? How many will you need? When will you need them? And how are you going to invite them into the community? Will they come in and be established independently? Will they come into some of your employed physician mechanisms? And how to do that. So that's the medical staff development plan. As I tried to suggest in this short webinar, that is essential, but it's only a component of the physician alignment strategy. If you think of your philosophy of embracing and supporting and nurturing and actively helping physicians, whether employed or not, to work with you in your journey to clinical integration, you won't be able to do that unless you have a medical staff development plan. So they are interrelated, but they are separate in that regard. So the medical staff development plan does recruitment, but you recruit into a philosophy, an alignment philosophy and strategy. I hope that is useful.
Okay, great. Thank you, Jim. Our next question I'll take here is, who should be involved in developing the physician alignment strategy or philosophy?
Probably one of the most important things you need to take away from your investment of an hour on this topic is the need to have physicians of all specialties at the table with you, understanding the need for a more explicit physician alignment strategy, at the table to help assess and evaluate the degree to which what you have for alignment is working or not working, and very importantly, work with you to define a roadmap into a brighter and stronger future. So key in terms of participation must be physicians, but you will want nursing leadership, you will want some of your clinical and allied health professions with you as well. And this is important enough that you might very well want to have a couple of board people that are engaged in certain key aspects of the strategic thinking and the strategic planning process that yields this new physician alignment strategy. So have a broad engagement of stakeholders, but probably central and a majority of the participants should be physicians themselves.
Great, thank you, Jim. You know, and I like this next question because I think others in our audience online right now probably are dealing with the same issue. This participant asks, we have some problems with trust between our physicians. How do you build some trust so we can get cooperation to build our physician alignment strategy?
That's a difficult question. I think everyone on this webinar knows how important trust is, but also how fragile it is. We've done some work over the last year studying trust between boards and physicians and managers for the Governance Institute. And one of the things that we've found is it takes a long time and a lot of work to build trust. Trust can be eroded and can be lost very quickly. So some of the factors that we would encourage you to keep in mind is that you must intentionally build trust. Trust involves openness and transparency and honesty and integrity in communications. You can't communicate enough with physicians about where you are, your soft spots, your blemishes, your plans, your hopes, your fears. And you also need to ask them as individuals and human beings and practitioners and entrepreneurs, what gets them up in the morning? What is making them nervous? What do they stare at the ceiling at 2 o'clock in the evening or the morning worrying about? And how can you be more friendly in your conversations to build and to earn trust with each other? No easy answer. I think it's frequent and open communications, honesty, open minds, open doors, open books. Physicians sometimes think information is not being shared with them. The more you can be very candid and open with all the facts, all the data, the good, the bad, and the ugly, it's more likely you can get trust. And that question is important. It's central to your effectiveness to invite them in and for them to be willing to participate to build the strategy, because if you don't have trust, you're not going to have sustainable engagement or participation, and you won't have a good alignment strategy, and you will not be able to be very successful to implement it. I hope that is useful.
Yeah, that is a difficult one. Thank you, Jim. That was our final question. I want to thank our participants who submitted those. Up on your screen now, you can see a few upcoming webinars we'd like to share with you. The first one listed there is actually hosted by ACHE, the American College of Healthcare Executives, but it's on a related topic, and our speaker today will be presenting that, so we wanted to share the opportunity to register with you. The others are the next two in our webinar series that we will be offering. You can register for any of those by going to our website on our events page and registering through that. That's at ihstrategy.com. That wraps up our presentation for today. We thank you for joining.